Hello guys, can you see and hear me? Hello guys, can you see and hear me? If I'm audible and visible, you can just give a thumbs up so that we can start the session. Good morning, Dr. KGB. Yeah. Okay, I think I'm audible and visible, so let us move on to the session. So I'm going to discuss around 50 to 52 EKGs in this session. Maybe I'll take 1 to 1.5 hours, hopefully. So we're going to discuss what all the possible EKGs that you might get in the exam. So remember, this is according to the NEET PG level. So I'm not going into the SS perspective at all. So this is for the NEET PG level, probably into the INA CET level. So let us quickly discuss what could be the possible EKGs and what could be the possible combinations that you can get in your exams. So first, I'm going to talk about chamber enlargement, chamber hypertrophies quickly. So this EKG is showing some sort of cardiac chamber enlargement. So if you look at this one, so you can see a clear-cut bifid P wave in lead 2, and you can see a predominantly negative complex in V1. So remember that in V1, you need to have a sort of biphasic complexes. Okay, so this is a normal P wave. Okay, it's a normal P wave. So biphasic complexes like this. If you're going to see more of negative complexes, okay, so positivity is there, but if you see a predominant negative complexes, it is actually suggestive of a left atrial enlargement in V1. Apart from that, in lead 2. So lead 2 is considered to be one of the best leads to look for the P waves technically. So in lead 2, if you're able to see a wide P wave. So what do you mean by the term wide P wave? If you're going to see more than 3 millimeter lengthy P waves. Okay, if the P wave length is more than 3 millimeters, so then you can probably call it as a left atrial enlargement. So two things I said. So one is in lead 2, if your P wave length is more than or equal to 3 millimeter, and in lead V1, if you see a predominantly negative complex, okay, normally it should be biphasic, but if you see a prominent negative complex in V1, so that is more suggestive of a left atrial enlargement rather than a right atrial enlargement. So you know, these kind of wide and bifid P waves are also referred to as something called as P mitral. So why it's called P mitral? Because technically speaking, to start with, in olden days and all, the mitral valve problems are the ones which typically tends to produce left atrial enlargement. That's why it's called as P mitral. And as expected, you see a kind of M-shaped P wave, isn't it? This kind of bifid P waves, M-shaped P waves. So this also suggests that it's very likely to be a P mitral. So M for mitral, bifid P waves. That's what we're going to see here. And what is the most common cause of left atrial enlargement as of now in the modern era? So remember, even though in older days, you know, like it's about the mitral valve problem that typically tends to produce left atrial enlargement, the most common cause of left atrial enlargement right now in the world is going to be systemic hypertension. Systemic hypertension is the most common cause of left atrial enlargement as of now. Okay. Now coming to this one. So look at this EKG. In this, what you're seeing is sort of a very positive, okay, P wave in the V1. So as I told you, if you're going to see a more negative P wave, okay, in V1, so that is suggestive of a left atrial enlargement. Instead, you see more of a positive P wave like this in V1. So that is more often suggestive of a right atrial enlargement in V1. And apart from that, you also know in lead 2, which is technically one of the best leads to look for the P wave. In lead 2, if you look at the P wave, so it's very clear that it is more tall than wide. So what is the criteria to say that it's a right atrial enlargement based on the P wave in the lead 2? So remember, if the P wave height, so let me put it in white, if the P wave height in lead 2, if it is going to be more than 2.5 millimeter, as I told you, P wave length more than 3 millimeter is suggestive of left atrial enlargement. Similarly, P wave height more than 2.5 millimeter is suggestive of right atrial enlargement. So remember, these kind of tall P waves, okay, so that's what we're talking about. These kind of tall P waves in lead 2 are also referred to as something called as P pulmonale. Tall P waves in lead 2 is also referred to as something called as P pulmonale. So because the number one cause of right atrial enlargement right now in the world is pulmonary hypertension due to any cause. Probably you can think about a COPD or some chronic lung disease causing pulmonary hypertension, but that is the number one cause of your right atrial enlargement and P pulmonale. So now you can understand why it is called as P pulmonale. Okay, now coming to this one. This is then another example of a chamber hypertrophy, but for a change in this example, it is going to be left ventricular hypertrophy. That's what we're dealing with. So when you talk about left ventricular hypertrophy, you might also understand that there could be an element of left atrial enlargement. So whenever there is a left ventricular hypertrophy, so please understand, because the left ventricular compliance is poor, so there could be increased left ventricular filling pressures that in turn could increase the left atrial pressures. So because of that, there could be left atrial enlargement, and as such you can see there is an element of left atrial enlargement as well. As you can see that there is a negative P wave or predominantly negative P wave in V1. And apart from that, you're also able to see a kind of a wide P wave, isn't it? Looks a little tall also, but it's more wide. So wide-ish P wave in lead 2. So that also suggests this patient is also having a kind of left atrial enlargement. But apart from that, this EKG is all about left ventricular hypertrophy. So what is the definition of left ventricular hypertrophy? Or what we can say, what is the EKG definition of left ventricular hypertrophy? Remember, at a NEET PG level, things are going to be very simple and straightforward. So all you need to know is something called as Sokolov-Lyon criteria. So remember, Sokolov-Lyon criteria is very specific in the sense if some EKG fulfills the Sokolov-Lyon criteria, very likely the patient is having left ventricular hypertrophy, but it's not a very sensitive criteria in the sense if you do not have the Sokolov-Lyon criteria that is fulfilled by a particular EKG, doesn't mean that the patient is not having LVH. Remember, to find out LVH, echocardiogram is considered to be very sensitive and specific, but EKG is considered to be very specific but not very sensitive for that regards. So what is Sokolov-Lyon criteria? You're going to take the S wave. Okay, you're going to take the S wave in V1, plus apart from that, you're going to take the R wave in either V5 or you're going to take the R wave in V6. Any one you can take. And if this is going to be more than 35 millimeter, then you can call that the patient is having left ventricular hypertrophy. Look at this one. So in V1, I think there's approximately some 15 millimeter of S wave height. And if you take in V6, so there's definitely, 1, 2, 3, 4, 5, 6, 7, 8 large boxes. I think V6 alone has a R wave height of approximately 40 millimeters. So definitely the combination of S in V1 and R in V5 or V6 is going to be surely more than 35 millimeter, and definitely this EKG is basically a left ventricular hypertrophy EKG. There is no doubt about that. There are multiple other criteria. For example, there is something called as R in AVL criteria. Please understand, not everything should fit into your diagnosis of LVH. I mean, not every criteria will be applicable in a particular EKG. So look at this one. So there is another criteria called R in AVL criteria. So if the R in AVL is more than 11 millimeter, even though here it's not fitting into this criteria, but generally I'm saying if R in AVL is more than 11 millimeter, then that is also very much suggestive of left ventricular hypertrophy if you do not have a left axis deviation. In case if you have a left axis deviation, then this number becomes around 18 to 19 millimeter. But nevertheless, that's not important for you. R in AVL, if it's more than 11 millimeter in a patient with a normal axis, then probably you can diagnose a left ventricular hypertrophy. Apart from that, we have Cornell's voltage criteria. We have something called as Rombold-Estes index. So that's too much of an ask. So for a NEET PG level, so all you need to know is the Sokolov-Lyon criteria for your NEET PG exam to diagnose left ventricular hypertrophy. So now moving on to the next chamber hypertrophy, that is right ventricular hypertrophy. So we know that for left ventricular hypertrophy, we have plenty of causes, but the number one cause once again is going to be systemic hypertension. So now coming to right ventricular hypertrophy. So how do you diagnose right ventricular hypertrophy? First of all, look at the R wave. Okay, in lead V1. So what does the criteria say? If R wave in V1, if it's going to be more than 6 millimeter, or we can say 7 millimeter and above, or more than 6 millimeter with a normal QRS. Normal QRS means I'm not talking about a wide QRS. The QRS width should be less than 120 milliseconds. That's very important. Okay, QRS width should be less than 120 milliseconds. Why that is important? Because if the QRS width is more than 120 milliseconds, and if you see a prominent R wave in V1, then that becomes a diagnosis of a right bundle branch block. Okay, so that is the reason why I should have a tall R wave in V1, plus at the same time I should have a narrow QRS, that is at least a QRS width of less than 120 milliseconds. So that can suggest that this patient is having a right ventricular hypertrophy. Or otherwise, we can also say that if the RS complex, or the RS ratio in V1 is more than 1. What I'm trying to say here, the height of the R wave is more than the height of the S wave. So that is the reason why RS ratio is more than 1 in V1 in the presence of a QRS width of less than 120 milliseconds is very much suggestive of right ventricular hypertrophy. Apart from that, you can also look at the S wave height, okay, in V5 or V6. For example, take the S wave height, okay, in V5 or V6. If it is going to be more than 6 millimeter, or if I can say the RS ratio in V6 especially, or V5 or V6, if it's going to be less than 1, or alternatively, then that is also very much suggestive of a right ventricular hypertrophy, but this should happen in the absence of wide QRS. So then you can diagnose it is a right ventricular hypertrophy. So do anyone know that there is a Sokolov-Lyon criteria for right ventricular hypertrophy as well? There is a Sokolov-Lyon criteria for right ventricular hypertrophy as well. So what is the criteria for right ventricular hypertrophy? So it is R wave in V1 plus your S wave in V5 or S wave in V6, any one, okay, or S wave in V6 if it's more than 10.5 millimeter. So then you can call it as right ventricular hypertrophy as per the Sokolov-Lyon criteria for RVH. So I don't know whether many of you know this or not in the first place, but there is a Sokolov-Lyon criteria for right ventricular hypertrophy as well. And looking at this one, okay, what is this one? So we are talking about axis first of all. So we are talking about how to find out cardiac axis in the first place. So I used to give a simple, like algorithm for finding out what is the axis. So look at lead 1, look at lead AVF, nothing more than that. So if lead 1 shows a predominantly positive complex and lead AVF shows a predominant positive complexes, it is very likely to be a normal axis. If lead 1 is showing a negative complex and lead AVF showing a predominantly positive complex, it indicates a right axis deviation. Similarly, if lead 1 is showing a negative complex and lead AVF also showing a negative complex, it's very likely to be a northwest axis, or we can call it as an extreme axis deviation. But more often than not, in this condition, your AVR also will be strongly showing predominantly positive complexes. On the other hand, if lead 1 is showing negative positive complex and lead AVF is showing negative complex, means it could be a normal axis or it could be a left axis. So the confusion can be sorted out by looking at lead 2. If lead 2 is showing predominantly positive complexes, it is very likely to be a normal axis, and lead 2, if it's showing a predominantly negative complex, then it's very likely to be a left axis deviation. So there are plenty of causes. We are not going to talk about what are the causes of right axis deviation and left axis deviation. But nevertheless, look at this EKG. In this EKG, the lead 1 is showing primarily positive complexes and lead AVF is showing primarily negative complexes. So we are in this domain. So it could be normal axis or left axis. In this situation, look at the lead 2. Here the lead 2 is showing predominantly negative complexes. So that is the reason I can say that this is a EKG that is showing left axis deviation. Okay, this is not an EKG with normal axis. And if you look at this EKG, for example, so see here. So here you are having a predominantly negative complex in lead 1, and you are having a predominantly positive complex in lead AVF. So this clearly suggests that this EKG is an EKG that is an example of a right axis deviation. And to some extent, I think you are able to see the classic S1 Q3 T3 pattern. So what is S1 Q3 T3 pattern? You have a S wave, and then you have a small Q wave, and then you will have a T wave inversion in lead 3. So the prominent S wave in lead 1, and then if you're going to have a Q wave in lead 3 and then a kind of T wave inversion in lead 3. So this is what we call as S1Q3T3 pattern. And even though many people think like S1Q3T3 means it is likely to be a pulmonary embolism, remember this finding is neither sensitive nor this finding is going to be specific for pulmonary embolism. This can be seen in a variety of other conditions as well. Even though at an undergrad level, if you talk about an S1Q3T3 pattern, it's considered to be pulmonary embolism, but this finding of S1Q3T3 is neither sensitive nor specific for the diagnosis of pulmonary embolism. It can be seen in plenty of other conditions as well. And look at this EKG. Actually, this is a EKG of a ventricular tachycardia, but what you're seeing here, what is the axis? That's what I want here. So look at lead 1. So lead 1 is showing a primarily negative complex. So this is the lead 1 complex. So lead 1 showing a primarily negative complex. And if you look at lead AVF is also showing a primary negative complex. And lead AVR is predominantly positive. Okay. So this clearly confirms that this EKG is showing a northwest axis, or we can call it as a extreme axis. Remember, there are very few conditions that produce extreme axis. We can say ventricular ectopics, ventricular tachycardia, and probably some bizarre conditions like hyperkalemia. It's very rare to have a northwest or extreme axis unless and until you have a lead reversal or wrongly placed leads in the body while taking the electrocardiogram. So, but some pathological condition that can produce northwest axis or extreme axis deviation is going to be your ventricular ectopic, that's very important, or ventricular tachycardia, which is nothing but a series of ventricular ectopics. That's what we call ventricular tachycardia. Plus at the same time, hyperkalemia also sometimes rarely can cause northwest axis or extreme axis deviation. Coming to the EKG number 8, so we are going into the zone of ischemic heart disease and ST segment problem. So here what you are seeing is hyperacute T waves. So you are seeing tall T waves, tall T waves, tall T waves. So more than looking at this tall T waves, you're also seeing a kind of symmetric T waves, right? So I think the T waves are absolutely symmetric. So remember, you don't see symmetric T wave normally. So T waves, even in a normal EKG, tends to be asymmetric. You never see a symmetric T wave. So whenever you see a tall, peaking, symmetric T wave, whenever you see a tall, peaking, symmetric T wave, so the DDs include hyperkalemia. And apart from that, the second most important differential diagnosis is going to be hyperacute myocardial infarction. Hyperacute myocardial infarction. There are multiple differential diagnoses, but these two are very, very important for exams. So how can you confirm that it's a hyperacute MI and it is not a hyperkalemia? It's very difficult to differentiate because both hyperkalemia as well as hyperacute myocardial infarction will have a tall, symmetric peaking T waves. But in case if you have an associated ST depression, if you are able to see an associated ST depression along with the tall T wave like this, then it goes towards a hyperacute MI. This finding of a ST depression, so let me draw that, this finding of a ST depression along with that, if you have a tall T wave like this, so this is the QRS, this is the ST segment that is depressed, and if you see a tall T wave like this, this combination is what we refer to as something called as D-Winter sign. Okay, this is very much suggestive of a hyperacute MI rather than a hyperkalemia. Remember, hypokalemia can produce ST segment depressions, but it's very rare to see a ST depression with hyperkalemia. So that is the reason this combination of ST depression with a tall T wave, which is what we call as D-Winter sign, is very much specific for hyperacute myocardial infarction. So this is an EKG that is suggestive of a hyperacute myocardial infarction, even though I cannot see any much D-Winter change here, but nevertheless, so this is an EKG of a patient who's coming with hyperacute MI, and that is evidenced by the fact that this patient is having a plenty of premature ventricular contractions as well. As you can see here, this patient is having a frequent runs of PVC. So why you get frequent runs of PVC? That is because in ischemic heart disease, during any ischemia to the heart, there will be a kind of ventricular myocardial irritation because of ischemia, and that is going to produce a lot of premature ventricular contractions like this. And if you see a lot of PVCs in a patient with ischemic heart disease, it indicates that they are always prone for development of ventricular tachycardia. So that's why there is a very, very hyperacute case of MI which is prone for development of ventricular tachyarrhythmias like VT, and you should treat them very promptly. And coming to this one, so this is a kind of a no-brainer EKG. So this is a clear-cut anterior wall myocardial infarction. So whenever you talk about an anterior wall myocardial infarction, a STEMI, so this is going to be an LAD occlusion for sure. There is no doubt about that. So this kind of EKGs are so common in your exam. So very, very basic EKG and a very common EKG in your exam. So what I'm seeing here, maybe in V1 you're seeing a little bit of ST elevation, but definitely you're seeing a lot of ST elevations in V2, V3, V4, V5, even in a little bit of V6, a little bit of even lead 1 is showing a little bit of lead AVL, even though the according to the criteria lead AVL is not showing significant ST elevation. But I know in the context of my clinical pictures, definitely this ST elevation is also going to be very significant, and definitely like this patient is having a anterior wall MI, which is probably due to LAD occlusion. So usually in this condition your LAD will be the culprit artery. And apart from that, there are plenty of other findings that are suggestive of myocardial infarction. Okay, a STEMI. So number one, you see a kind of a convex ST segment elevation. Okay, so this is a convex ST segment elevation, or these kind of ST segment elevations are called as tombstone ST segment elevation. So whenever you see a convex or a tombstone ST segment elevation, so it is very likely suggestive of a myocardial infarction, STEMI. And apart from that, I think you're also able to see this Q waves, pathological Q waves. Remember, whenever the Q waves are more than 2 millimeter in depth and more than 1 millimeter in width, these are called as pathological Q waves, and here you are able to see the pathological Q waves as well, and that is the reason why this is very much suggestive of a STEMI. So there are a lot of pointers towards a STEMI here, and apart from that, you can see the reciprocal changes. You know, certain leads will show ST segment elevation, and certain other leads called as reciprocal leads tend to show ST segment depressions in a patient with STEMI, and here are the leads that are showing ST segment depression slightly, maybe lead 3 and lead AV, if I can say, they are showing a bit of ST segment depressions as well. So this is very much in favor of a diagnosis of a STEMI, typically an anterior wall myocardial infarction because of LAD occlusion. And look at this one. So this is an EKG that is showing a STEMI as well, and these are clear-cut convex and tombstone ST elevations. There is no doubt about that, but you're seeing in the inferior leads, lead 2, 3 and AVF. So these are the 3 leads that are showing your characteristic ST segment elevation, and apart from that, I think you're seeing reciprocal changes as well. So in lead 1, you're seeing a bit of reciprocal change. In lead AVL also you can see a bit of reciprocal change, and apart from that, in lead V4 you're seeing a bit of reciprocal change. Yeah, in lead V2 you're seeing a reciprocal change, whatever it is. So this is a kind of a EKG that shows a characteristic STEMI, that is an inferior wall myocardial infarction. And apart from that, there is one other characteristic finding that you're seeing in lead V2. I don't know how many of you are able to appreciate the change in lead V2. In lead V1 or V2, if you're able to see this kind of tall R waves, generally in lead V1 and V2, you don't see tall R waves. If you are seeing this kind of tall R waves in the setting of ischemic cardias and chest pain, okay, tall R wave, number one. Apart from that, you are seeing the characteristic ST segment depression, and apart from that, you are seeing a upright T wave. T wave is upright. So this combination leads to what diagnosis? This combination, you're seeing a tall R wave in lead V1 or V2. Along with that, you have a ST segment depression and an upright T wave. So this is a typical posterior wall myocardial infarction. Okay, so this can happen alone, or more commonly it's going to happen along with inferior wall myocardial infarction. So remember, in lead V1, V2, you never see a tall R wave. Whenever there is a suspicion of ischemic heart disease, and if you see a tall R wave in lead V1 or V2, it is very much suggestive of posterior wall myocardial infarction. The characteristic pattern of posterior wall MI is going to be your tall R wave with ST segment depression and your upright T wave. So remember, most of the times posterior wall MI will happen along with your inferior MI, but sometimes it can happen alone as well. But before that, what is the definition of ST segment elevation? What is the definition of significant ST segment elevation? When you will call it as a significant ST segment elevation. So remember, number one, you should have at least 1 millimeter plus ST segment elevation in at least 2 anatomically contiguous leads. anatomically contiguous leads. You should have at least 1 millimeter of ST elevation in at least 2 anatomically contiguous leads. So anatomically contiguous means either in the precordial leads or it could be in the limb leads also. But what is the exception for this rule? So the exception for these rules will be your lead V2 and V3 alone. So in lead V2 and V3 alone, you need more than 1 millimeter to tell it as a significant ST segment elevation. So in the sense, for males, it should be at least 2 millimeter and above. For females, it should be at least 1.5 millimeter and above. 1.5 millimeter and above. So then only you can call it as a significant ST segment elevation as far as lead V2 and V3 is concerned. Again, another exception to the rule is in posterior leads, which is used to find out post-valve myocardial infarction, and in right-sided leads, which is used to diagnose right ventricular myocardial infarction. Because these leads are very sensitive for the diagnosis of STEMI, you need just 0.5 millimeter here. So not more than that. So the 1 millimeter rule is standard, but there is some exception for that. There are some exceptions for that. So one exception will be in lead V2 and V3 where you need more than 1 millimeter, and posterior and right sided leads, because they are sensitive, you need less than 1 millimeter. These are the two exceptions to say that the patient is having a significant ST segment elevation. So remember, whenever you have an inferior wall myocardial infarction, please understand it could be a right coronary artery culprit or it could be a left circumflex culprit. Any one could be there. The easiest way to find out RCA versus circumflex culprit is to look at the ST segment depressions in lead AVL and lead 1. In case if your ST segment depression in AVL is more than lead 1, it is very likely to be a right coronary artery culprit. And again look at ST segment elevations in lead 2 and lead 3. In case if your ST segment elevation in lead 3 is more than lead 2, then again it is suggestive of a right coronary artery culprit. So as you can see in this EKG, the ST depression in AVL is definitely more than that of what is happening in lead 1, and ST elevation in lead 3 is definitely more than that of what is happening in lead 2. So I can safely conclude that this patient is having a right coronary artery culprit more often than not. Remember, presence of post-valve MI will not tell you whether it's a RCA or L6 culprit, because post-valve MI once again can happen in both RCA as well as left circumflex culprit. But if you have a right ventricular MI, it confirms that it's a right coronary artery culprit, because RVMI cannot happen with left circumflex occlusion. But the gold standard way to find out right ventricular MI or post-valve MI is going to be the right-sided leads and the posterior leads respectively, but still your standard 12 lead EKG itself will give you some idea about whether the patient is having an associated RVMI or post-valve MI or not. Coming to this one, so these are some of the important differential diagnoses as far as ST elevation is concerned. ST elevations has a lot of differential diagnoses, but I'm going to show only the most important differential diagnosis. So here is your first differential diagnosis. Let me tell you the case history so that you will understand. So this patient has come to your emergency with some unrelated problem. Let us assume this patient has come with a fever, and you're taking an EKG. He's a young, healthy male, okay, who's having an athletic build, coming with fever to your emergency and presenting with this kind of an EKG. You are a little bit worried because this patient is showing ST segment elevation multiple leads. You can see in V4, V5, V6. This patient is showing ST elevations in multiple leads. So you are a little worried, but one thing should tell you that it's a benign condition, that this presence of J waves. Okay, you can see a sort of J wave complexes, especially obvious in V4 and V5, especially obvious in V4 and V5. If you are able to see this kind of J wave complexes in V4 and V5, these are called as fish hook pattern, which is very much suggestive of benign early repolarization syndrome. So this tends to happen in patients who are generally males who are having athletic build, muscular, so where they have a quicker repolarization. So normally, like you should have a depolarization and then there should be a time before you get a repolarization, right? So that's a T wave. But in these patients, what happens is they tend to get a depolarization, and even before the depolarization is complete, you tend to get a repolarization also, so that your ST segment appears a little elevated. So this is a kind of a benign condition basically, so we call it as benign early repolarization syndrome. And the one of the characteristic findings of a benign ERS is going to be this J waves. Okay, these are called as J waves. These are called as Fischhoek waves, or we can call it as Fischhoek pattern, especially seen in leads V4 and V5. So that confirms that. I mean, you can see a little bit of this kind of Fischhooks in lead 2 also, but they are very characteristic in V4 and V5. And they are generally seen in leads that show big R waves. So those are the leads that are going to show that Fischhooks technically. So this is another example of a patient. Let me tell you the history so that you will be able to tell the answer pretty easily. So this is a patient who had a history of URI 1 week ago, now coming with chest pain. Okay, the chest pain is sharp and it is probably related to the trapezius, and the chest pain is more on deep inspiration. So, and you are able to hear a kind of a rub-like sound in the precordial examination as well. So you can easily make out by clinical history itself even without looking at the EKG. So this is an EKG of a pericarditis. Okay, so this is an EKG of a pericarditis. But what are the findings that you see in a pericarditis? So first of all, the number one finding is going to be diffuse ST segment elevations or global ST segment elevations. Even though we call it as diffuse ST segment elevations pericarditis is more often than not going to be found in inferior and lateral leads. But technically speaking, they are diffuse ST segment elevation, or we can call it as global ST segment elevations. So as expected, you can see ST segment elevations in lead 2, you can see lead 3, you can see a little bit in lead 1, definitely not in lead avial, you can see a little bit in lead AVF as well. And what about V4? Yes, you are able to see. V5 you are able to see, and V6 also a little bit of ST elevation is there. So this is a kind of a global ST elevation, that's what I can say. But more importantly, there should be some associated findings to say it's a pericarditis. Why? It could be an MI also. So you need to differentiate from myocardial infarction. So how will you tell it's not a myocardial infarction? Number one, you will not be seeing any reciprocal ST segment depression. You don't see reciprocal ST segment depression. So remember, leave out the lead AVR. AVR is a global negative lead. So you should not take AVR into account. But apart from that, you're not seeing any reciprocal ST segment depressions. It's only ST elevations everywhere in the EKG. And apart from that, you will be able to see PR elevations, PR depressions, and sometimes TP segment downsloping also. So remember that this patient is having a ST segment elevation, but there is a bit of PR segment depression as well. Remember, even though you see PR segment depression in majority of the limb leads, in AVR you will see PR segment elevation. That's also very, very important point. If you see PR elevation in AVR and PR depression in all the other leads, that is also very much suggestive of pericarditis. And Chakravarti is asking about whether this is also kind of Fischhoek pattern. No, this is not a Fischhoek. Fischhoek is very characteristic. Sometimes you can see this kind of J wave. So Fischhoek will be something like this. It will be very characteristic and separate. I don't think this is suggestive of Fischhoek. So this is just suggestive of a saddle ST elevation. And more importantly, in pericarditis, you're going to see this kind of saddle shaped ST segment elevation. These are concave ST elevations. So these are saddle shaped, saddle ST elevations, or we can say concave ST segment elevation. So that's what is going to happen in a patient with pericarditis. And of course, like depending on the type of pericarditis, you're going to treat with analgesics like NSAIDs, corticosteroids, or probably just with aspirin if it's a post-MI pericarditis. So what are the ECG changes of pericarditis? Diffuse or global ST segment elevations, which will be saddle shaped or concave. PR segment depressions except in AVR, where you will see PR segment elevations, and there will be reciprocal, there will be no reciprocal ST segment depressions as well. So Dr. Ipsita Basu is asking about how to differentiate J waves from Osborne waves and Brugada pattern. We'll talk about that in a while. So what are the J wave syndromes? At the end of the lecture, I will talk about that. Maybe we have another half an hour of time. So this is the EKG number 13. So what you're seeing here you're seeing predominantly ST segment depressions. As you can see in lead V2, lead V3, you're seeing ST segment depressions. But what you're seeing apart from that, so I told you in a patient who's coming with chest pain, you should not see a prominent R wave in lead V1 or V2. But here in V2, you're seeing a prominent R wave, and on top of that, you're seeing a ST segment depression, and you're seeing a upright T wave. So now you can make the diagnosis yourself. So if you see a prominent R wave in lead V1 or V2 in a patient who's coming with ischemic symptoms and chest pain, and if you see a ST segment depression, and if you see an upright T wave like this, as I've told you, this is suggestive of a post-dual MI. Even though the gold standard for finding out post-dual MI is going to be the posterior leads, but the standard 12 lead EKG itself is going to give you some clues. But understand that this patient is not having inferior MI also. If you see 2, 3 and AVF, they are perfectly fine. So in fact, they are showing some reciprocal changes like ST segment depression, but so you don't see ST elevations in 2, 3 AVF. So this patient is not having an inferior MI, but having an isolated posterior MI. Please understand that ST segment depressions, two things are very important. They are non-localizing. Number one, except in few conditions like posterior MI, ST segment depressions are generally non-localizing. Point number one. And ST segment depressions are non-specific findings. You need to always correlate clinically. So what is the patient's symptoms? When you talk about ST depressions, except in situations like posterior MI where it can be localizing to some extent, but ST segment depressions in a standard 12 lead EKG are generally non-localizing. You cannot say where exactly the problem is in the heart. And second, it is very non-specific and you need to always correlate with your clinical history and the clinical background. Coming to this EKG, so this is an EKG which definitely shows significant ST segment depressions in multiple leads. You can see ST segment depressions in V3, you can see ST segment depressions in V4, V5, V6, you can see ST segment depressions in lead 2, lead 3, then you are able to see ST segment depressions in lead AVF. So even in lead 1, you're able to see ST segment depression. So what I'm trying to say is this is an EKG that shows ST segment depression in more than or equal to 5 leads. So whenever you see ST segment depression in more than or equal to 5 leads, diffuse ST segment depressions, always look at lead AVR. Okay, always look at lead AVR. So in case if you see this kind of ST elevations in lead AVR, it more often goes towards a left main coronary artery disease. So this is an LMCA disease, or sometimes it could be a triple vessel disease. We call it as 3 vessel disease or triple vessel disease. Okay, so but most often than not, I'm going to diagnose a LMCA disease. This is a kind of a severe stenosis of left main coronary artery, or you can see this pattern in NSTEMI also or NST-ACS also, but I'm going to diagnose more of LMCA stenosis in this condition, or a critical LMCA occlusion, or we can even diagnose a triple vessel disease based on this EKG. So remember, ST segment depressions in more than 5 leads along with ST elevation in lead AVR is more suggestive of LMCA disease and sometimes a triple vessel disease as well. And coming to this EKG, so what you're seeing here is a kind of just a T wave inversion in V4, little in V4, V5, V6, and maybe in 1 and AVL. All you're seeing is just T wave inversions and nothing more than that. So remember to tell T wave inversions to be specific. So number one, T wave inversions, if they are happening in lateral leads, okay, like V5, V6, 1 AVL, they're considered to be slightly specific. And apart from that, if it's more than 1 millimeter, the T wave inversion is more than 1 millimeter, it's considered to be specific. Especially if they are more than 3 millimeter, they are very, very specific. But at least they should be at least more than or equal to 1 millimeter. And T wave inversions in early precordial leads, V1, V2, V3 and all, are not considered to be very specific unless and until you suspect some specific disorder. Like in Caucasians, ARVC is very common. In a Caucasian male or a female, any T wave inversion beyond V2 is considered to be very, very significant, and they will screen for arrhythmogenic right ventricular cardiomyopathy. But I'm not going to go into the details of all those things. But nevertheless, T wave inversions in V1, V2, at least in India, up to V3, we don't consider that significant unless and until it's very deep. But the lateral T wave inversions, especially beyond V4, like V5, V6, 1 AVL and all, are considered to be very specific for myocardial ischemia. And especially if it's more than or equal to 1 millimeter, they can be considered specific for myocardial ischemia. So remember, in STEMI, you're going to see ST segment elevations, but in NST-ACS, you're going to you're going to get predominantly ST segment depressions plus or minus T wave inversions. Okay, this is what you're going to get in NST-ACS. Remember, there are two types of NST-ACS. One is NSTEMI and second is unstable angina. And how can you differentiate between NSTEMI and unstable angina? It is based on the troponins. Suppose if your troponins are positive, it is going to be STMI. If it's going to be troponin negative, then you can diagnose unstable angina in this situation. And Dr. Binay is asking about hypokalemia. Remember hypokalemia, I will talk about that in a while. So I think we have plenty of other ECGs to discuss. That time I'll talk about hypokalemia. So this is an EKG of NSTACs, or we can say like myocardial ischemia. Remember, ST segment depressions and T wave inversions are not very localizing. You cannot clearly say that this is the area of the myocardium that is ischemic based on ST segment depressions or T wave inversions. But with ST elevations, you can say which area of the myocardium is probably ischemic or infarcted. And coming to this one, okay, so these are EKGs that are suggestive of a syndrome called as Wellens syndrome. So this is an example of a type A Wellens or a type 1 Wellens, as some textbooks call. So what you will see is a kind of biphasic T waves in the mid precordial leads. What are mid precordial leads? V2, V3 and V4 are called as mid precordial leads. If you see this kind of biphasic T waves, okay, like this in lead V2, V3, V4, this is more suggestive of a type A Wellens. So whenever you hear the term Wellens syndrome, it almost always indicates a critical LAD occlusion. Okay, critical LAD occlusion. So whenever you hear the word Wellens, it almost always indicates a critical left antedescending artery occlusion. So you need to immediately take the patient to the cath lab. So this is an example of a type B Wellens or a type 2 Wellens. So again, if I use the term Wellens always almost means it's a critical LAD occlusion. So what you're seeing in type B Wellens, what you're seeing kind of deep symmetric T wave inversions. In fact, these T wave inversions are more than 3 to 5 millimeters. So these are deep symmetric T wave inversions in the precordial leads. Okay, in V2, V3, V4, V5, V6, there are multiple differential diagnoses for this kind of deep symmetric T wave inversions. That is the reason I said whenever you have ST segment depressions or T wave inversions, they are very non-specific findings, and you need to always correlate clinically. If this patient is coming with chest pain, then probably with this kind of an EKG, I'm going to make a diagnosis of critical LAD occlusion. So this is a type B Wellens, which is also very commonly asked in exams. And coming to the 18th EKG, so this is another example of a ST segment depression. There's another example of an ST segment depression, as you can see, especially in lead 2-3 AVF, but this is showing more of a hockey stick ST segment depressions. Hockey stick ST segment depressions. This is an example of a digitalis effect. Remember, whenever you see this kind of hockey stick ST depressions, this is digitalis effect and not digitalis toxicity. Remember, digitalis toxicity is different, digitalis effect is different. Anyone who's taking digitalis can have this kind of hockey stick ST segment depressions in the EKG, and this is a benign finding. So this is not finding that is that's going to correlate with digitalis toxicity. And as expected, this EKG has another finding also. This is a patient with atrial fibrillation. Remember, one of the most common indications for giving digitalis right now in the world in modern practice is atrial fibrillation in a patient who's having heart failure. Okay, in that situation, digitalis is going to be very, very effective. And as such, I told you multiple times, it's not digitalis toxicity, it is just a digitalis effect. Okay, so this patient is also in atrial fibrillation, as explained by the fact that there are no P waves. Literally, you're not able to see any P waves, and you're seeing a irregular rhythm as well. So this patient is in atrial fibrillation. So one of the reasons for giving digitalis is going to be your AF in a patient who's having heart failure. So as such, this patient is having a controlled ventricular rhythm and is having atrial fibrillation, as you can see. And coming to the 19th EKG, so we are going into the conduction blocks. So this is an example of a left bundle branch block. Okay, to start with. So, I mean, in exams, it's very easy to find out a left bundle branch block. So look at the lead V1. So the first thing is look at the lead V1. So that's what all you need to look out for. So in the lead V1, if you see a wide QRS, so what do you mean by a wide QRS? Wide QRS means your QRS width should be more than or equal to 0.12 seconds or 120 milliseconds. So if that is the case, that is wide QRS. If you have wide QRS, along with that, if you see this kind of QS complexes or a predominantly negative complex like this, that is very much suggestive of a left bundle branch block. Remember, there is another very, very close differential diagnosis for left bundle branch block pattern in your exams. That is paced rhythms. Okay, paced rhythms. Paced rhythms is another very, very, very close, or ventricular paced rhythms. especially those leads, I mean, usually commonly placed in the right ventricles. That is the reason you get a left bundle branch block pattern. But how will you differentiate LBB, a true left bundle branch block, from a paced rhythm? So look for the pacer spikes. So if you are able to see some sort of pacer spikes like this before every QRS complex, then that is more suggestive of a paced rhythm. So look for those pacer spikes very carefully in exam whenever you see a left bundle branch block pattern like this. But if you don't see pacer spikes as in this EKG, it is very much suggestive of a true left bundle branch block. So how to find out a left bundle branch block? Just look at lead V1. If you have a white QRS and if you have a negative QRS complex predominantly, so or a QS complex like this, so that is very much suggestive of a left bundle branch block. And apart from that, in lead 1 and in lead AVL, so where is that AVL? Yeah, lead 1 and lead AVL, you will see this kind of monomorphic positive R wave complexes. So for diagnosis in your exams at a NEET PG level, these and all are not important, but maybe you can think it as a additional finding. If you have a monomorphic QRS complexes or a monomorphic R wave in lead 1 and AVL, just a positive complex in lead 1 and AVL with a white QRS, that is also very much suggestive of a left bundle branch block. But what is more important? Just look at lead V1. If you have a white QRS with a prominent negative deflection or a QS complex, that is left bundle branch block according to your exams at least. So this is a clear-cut example of a right bundle branch block. Okay, as you can see here. So how will you say it's a right bundle branch block? Either you should have a characteristic pattern like this. This is an example of a characteristic M pattern. Apart from that, you should have a white QRS to say it is a complete right bundle branch block. So this patient is definitely having a white QRS. There is no doubt about it. If you count the number of small boxes, it's 1, 2, definitely 3+ small boxes are there. So definitely this patient is having QRS width of 0.12 seconds or more, because one small box in x-axis is going to correspond to 0.04 seconds. So definitely this patient is having a white QRS. Along with that, if you see this characteristic M pattern, or if you see a predominantly positive complex, if you don't see that characteristic M pattern, if you see a prominent positive complex in lead V1, so that is also very much suggestive of a right bundle branch block. So this patient is actually having a RBB pattern, and in fact a true right bundle branch block in the TKG. So look at this one. So now coming to the fascicular blocks, this is the patient who's having a left anterior fascicular block. So what are the findings that are suggestive of left anterior fascicular block? Number 1, so you will have this kind of RS complexes, small R wave and a big S wave. So these kind of RS complexes in lead 2, 3 and AVF. In inferior leads, you will see this kind of small RS complexes, and apart from that, you will be seeing this kind of QR complexes. Okay, small Q wave with big R waves. Okay, these kind of QR complexes in lead 1 and AVL. So if you see this, so this is very much suggestive of a left anterior fascicular block. But can anyone say what is the axis deviation here? So which means that axis will be the axis of the left anterior fascicular block also. Can anyone say what is the axis deviation here? I told you to find out the frontal plane axis, you have to look at the lead 1. In this case, it is positive. Maybe I can put a different color. So in this case, it's positive. And if you look at lead AVF, it is negative. So when I said, like, whenever your lead 1 is positive and lead AVF is negative, it could be a normal axis or it could be a left axis. But look at lead 2. If lead 2 is positive in that situation, it is very likely to be a normal axis. In this case, it's negative. So I can safely conclude that this patient is having a left axis deviation. That's correct. So remember, in a left anterior fascicular block, you get left axis deviation only. In fact, one of the important causes in exams that you should need to know about left axis deviation is left anterior fascicular block. And apart from that, another important finding is going to be the poor R wave progression. So what do you mean by poor R wave progression? Normally, R wave in V1 will be small, then it becomes a little big in V2, then becomes a little big in V3. Then at V4, the R wave will dominate. It will be more than the S wave. Then in V5 and V6, all you will see is only about R waves and R waves. S waves will be very, very small, or sometimes it will not be there at all. So that's what we call it as normal R wave progression. So according to normal R wave progression, if you want to use the term normal R wave progression, remember your RS ratio should become more than 1 at V3 or V4 minimum. At V3 or V4, your R wave should become bigger than the S wave. Initially, R wave will be small in V1. Then as you go through the V2, V3, V4, V5, V6, at V3 or V4, your R wave should become bigger than the S wave. That's what we call it as normal transition. But in patients with left anterior fascicular block, you have a poor R wave progression. But there are multiple DDs for poor R wave progression. One of the most common DDs is ischemic heart disease itself. If you have an anterior MI or a old anterior MI, that itself is going to cause a poor R wave progression because of the infarcted territory in the anterior wall. You are not going to get the R waves at all. So that's fine, all right. But one of the other causes of poor R wave progression is left anterior fascicular block. As you can see here, at V3 and V4, still your R waves are not prominent and your S waves are the ones which are dominant. So that is the reason why it is called poor R wave progression. So another important cause of poor R wave progression is left anterior fascicular block. So what are you going to see in LAFB? You're going to see that classical RS complexes in lead 2, 3 AVF and QR complexes in lead 1 and AVL. And apart from that, you see left axis deviation, and apart from that, you're going to see poor R wave progression as well. And look at this one. So this is an example of a left posterior fascicular block. So if I ask you what is the axis that is seen in the ECG, you'll be clearly saying that lead 1 is primarily negative, but lead AF is primarily positive. So this clearly suggests that this patient is having a right axis deviation as well. And what are the findings that you will expect in a patient with left posterior fascicular block and not anterior fascicular block? It's the ulta of anterior fascicular block. You're going to see RS complexes in lead 1 and AVL. Lead 1 and AVL are going to show RS complexes, whereas lead 2, 3 and AVF are going to show this kind of QR complexes. Okay, lead 2, 3 and AVF are going to show QR complexes. So this pattern is very much suggestive of a left posterior fascicular block. And coming to this one, so this is an example of a bifascicular block. So this is an EKG that is an example of a bifascicular block. So what is bifascicular block? If you have a right bundle branch block, plus along with it, if you have a left anterior fascicular block or left posterior fascicular block, but most often it will be an anterior fascicular block. In that situation, you're going to call it as a bifascicular block. So it's very clear that this patient is having a white QRS. Along with white QRS, you're having a prominent positive complex. Okay, or you can see that RSR pattern is there, M pattern is there, whatever it is. So this is very much suggestive of a right bundle branch block. There is no doubt about that. And apart from that, if you look at lead 2, you are seeing a RS complex in not only lead 2, in lead 3 and AVF also. And apart from that, in lead 1 and AVL, you are able to see this QR complexes. So this is very much suggestive of an associated left anterior fascicular block also. But can any one of you tell what is the axis that is seen in this EKG? So look at lead 1. Lead 1 is predominantly positive. And look at lead AVF, it's predominantly negative. In this situation, it could be a normal axis or left axis. But look at lead 2, it's predominantly negative. So I can safely conclude that this patient is having a left axis deviation, right? So, hence proved, isn't it? So this patient is having a right bundle branch block, and this patient is also having a left anterior fascicular block and a left axis deviation because of the anterior fascicular block. So that's why this patient is likely to have a bifascicular block. And coming to the next one, 24th EKG, this is a patient who's having a trifascicular block. This is a patient who's having a trifascicular block. Trifascicular block in the sense you're going to have a right bundle branch block plus a left anterior fascicular block or a left posterior fascicular block, plus you will be having a first degree heart block. So what do you mean by first degree heart block or first degree AV block? You're going to have a prolonged PR interval. You're going to have a prolonged PR interval. So this is what we called as first degree heart block. So look at this patient. This patient is surely having that white QRS with the characteristic M or a predominantly positive complex in V1, so which is very much suggestive of a right bundle branch block. And apart from that, this patient is having left anterior fascicular block. As you can see here, there is RS complex in 2, 3 and AVF, and you have a bit of QR complex in lead 1 and AVL. And as you can see here, this patient is having a left axis deviation. Lead 1 is positive, lead AVF is negative, and lead 2 is also negative. So I can safely conclude that this patient is having a left axis deviation, and that is because of associated background left anterior fascicular block. And on top of that, this patient is also having a prolonged PR interval. As you can see, there is a significantly prolonged PR interval. So here is your P wave and here is your QRS complex. And when you call it as a prolonged PR interval, whenever your PR interval is more than 0.2 seconds, that is whenever it is more than 200 milliseconds, or we can say whenever it is more than 5 small boxes, you can say it is a prolonged PR interval. So here definitely the patient is also having a prolonged PR interval suggestive of a first degree heart block. So this ECG is very much suggestive of a trifascicular block. RBB plus LAFB plus there is a prolonged PR also. And coming to this one, so this is an example of a sinus bradycardia. So as such, if you want to diagnose a sinus bradycardia, first of all, you should have P waves followed by QRS complexes in the ratio of probably 1:1. You should not have any missed beats in between. Rhythm should be, at least the rhythm will be predominantly regular. So this patient is very likely having a sinus bradycardia and nothing more. This is a patient with severe hypothyroidism and mixed edema, and this patient is very likely to have a sinus bradycardia. And what is the heart rate here? You know how to find out the heart rate? So 300 divided by number of large boxes between any two RR interval, between any two QRS complexes. Any two QRS complexes, I can say. Any two QRS complexes. So this is how you calculate the heart rate. So whenever the number of large boxes between two QRS complexes are more than 5, okay, two QRS complexes are more than 5, it is very much suggestive of a bradycardia, because by default, if the number of large boxes between two QRS complexes more than 5, the heart rate will become less than 60. As you can see here, 1, 2, 3, 4, 5, 6, almost 7 large boxes are there approximately. So the heart rate is definitely somewhere around 40 to 45, I can say, nothing more than that here. So it's a significant sinus bradycardia in this EKG. And look at this one. So this is an example of a sick sinus syndrome. So this is an EKG that's an example of a sick sinus syndrome. So here the patient is having long sinus pauses. So look at this one. Here the patient is having a P wave and a QRS complex, all right. Here you have a P wave and a QRS complex, all right. But look at the rate in between. So what is the rate in between these two QRS complexes? You have 1 large box, 2 large box, 3 large box, and 4 large box. So which means the rate between these two QRS complexes is 75 beats per minute. Which means the heart rate is 75. At this place, the heart rate is 75, which is normal heart rate. But look at this area. What is happening? Here, abruptly, you're not having any P wave. So you got a P wave here, and suddenly the P wave didn't come. After that, the P wave has not come, has not taken place. And after a long pause, you're getting a P wave again. So this kind of absent P wave causing a long flat line is what we call as sinus pause. And remember why it is called a sick sinus syndrome? Because you are having a normal heart rate and suddenly your sinus fails to fire. A sinus node fails to fire. So that is why this is an example of a sick sinus syndrome. Sick sinus means unpredictable. You are not able to predict at what point you will have a absence of P wave. So look at the heart rate here. So definitely it's more than 5 large boxes, 1, 2, 3, 4, 5, 6, 7, 8, almost 9 large boxes. So at this point, the heart rate is not even like 20 or 30. So that is the reason why. So this patient is very likely to have a sick sinus syndrome. There are long sinus pauses here, alternating with normal heart rates. And this is another example of a sick sinus syndrome. Sometimes it can be extreme like this. So in this example, you are seeing a tachybrady syndrome. Okay, in this finding, in this case of a sick sinus syndrome, you are seeing a tachybrady syndrome. So what's happening here is you are seeing a P wave and then followed by a QRS complex. So definitely this is a sinus beat. There's no doubt about that. This is a definite sinus beat. And on top of that, what you're seeing here is suddenly there is a long sinus pause. You're not seeing any P wave and there is no QRS complexes also. And this is leading to no QRS also. So you are seeing such a long sinus pause, and this is again a case of sick sinus syndrome only. But look at these areas here. Here you are having tachycardia or bradycardia. Look at the number of large boxes between these two QRS complexes. It's just 1, 2, and not even 3. So as I told you, more than 5 large boxes between two QRS is bradycardia. But if you have less than 3 large boxes between two QRS complexes, that is tachycardia. Okay, so the heart rate is high in that for that matters. But here what you are seeing is a patient with tachycardia. Okay, suddenly there is no sinus impulse at all, resulting in no QRS complexes. So that is why this is another example of a sick sinus syndrome, and this is a tachybrady syndrome. And if you want to go deeper, look at this one. Look at this beats. So this QRS, these QRS complexes does not have a preceding P wave at all. These complexes does not have a preceding P wave at all. So what does that mean? So this also means that these complexes are not sinus in origin. These complexes are junctional complexes. That's why this patient is having a junctional tachycardia, but they are having occasional sinus beats also. Apart from that, they are having long sinus pauses, which means some escape rhythm is originating. So we know that the sinus is sick here. So the heart is trying to compensate by pushing some escape rhythms. In this case, it's the junctional tachycardia, that's the escape here. So that's why there are some runs of junctional tachycardia in between without P waves. It's happening. That's why I'm saying it's a junctional rhythm. And on top of that, you are having a long sinus pause also. This is another example of a sick sinus syndrome. In this case, it's a tachybrady syndrome. It's a very unique case, basically. And coming to this example, so we are going into AV blocks. I already showed you what is first degree AV block. That is prolonged PR interval. I showed that in the trifascicular block itself. Now, this is an example of a Wenckebach phenomenon. Wenckebach is also called as Mobitz 1. Okay, it's a Mobitz 1 block. So what you're seeing here is a patient who's having a sequential prolongation of the PR interval, then followed by you have a P wave, and you don't have the QRS. QRS is getting missed here. So if this kind of blocked P waves are there, then only you are going to diagnose a Mobitz. Please understand, in sick sinus syndrome, the P waves itself are not there. You can see there are P waves here. Okay, you have a P wave, and after that you don't get a P wave itself. Okay, you don't have a P wave itself in sick sinus syndrome. But in a case of Mobitz, you have the P wave, but it is blocked. That's what is the very important difference. Sometimes in exam, you might be confusing with sinus arrest and sick sinus syndrome with Mobitz. So that's why I'm telling this point. That's very important. So if you have a P wave which is not conducting, or if you have a P wave that is not getting translated into QRS complexes, in that situation only you're going to diagnose a Mobitz. Okay. If you don't have a P wave at all, so in that situation you're going to diagnose a sinus arrest or probably a sick sinus syndrome. So here you have a sequential prolonging of the PR interval, then followed by one missed beat. In the sense, P wave is there, but QRS complexes are not there. So this is very much suggestive of a Wenckebach, or we can call it as a Mobitz type 1 block. Mobitz type 1 block. So, and one more important thing about Mobitz type 1 block is about the varying PR interval. So please understand, this varying PR interval is one of the quintessential features of diagnosing Mobitz 1. Without this varying PR interval, you will not be able to diagnose a Mobitz 1. As you can see, if you take one particular group of QRS complexes, it's very clear that there is a varying PR, which means that prolongation in PR is what I'm talking about, the varying PR. So this varying PR is a quintessential prerequisite for diagnosing Mobitz 1. Otherwise, you will not be able to diagnose Mobitz 1. Please understand. So this is a patient with Wenckebach phenomenon. And here is an example of a Mobitz 2. So remember, when you want to diagnose a Mobitz, as I told you, there should be a blocked P wave. So first always look for the blocked P wave. So here you have a P wave that is not getting conducted. Okay, you don't have the QRS here, which means you have a P wave which is not getting conducted. So that's why it's a Mobitz. If you do not have the P wave itself in the first place, that will be a sinus arrest, or it will be a sick sinus syndrome, because you have a P wave that's non-conducted here. So this is very likely to be a Mobitz. But as I told you, you need to know whether it's a Mobitz 1 or a Mobitz 2. How will you find out it's a Mobitz 1 or a Mobitz 2? Look at the PR interval. So look, I mean, I don't think this is a Mobitz 2. Sorry for that. I think this is also an example of Mobitz 1 only. So look at this PR interval. So you have a PR interval here, and then you have another PR interval here. You have another PR interval here. So, I mean, leave alone the fact that whether it is progressively increasing or not. But all you're seeing is definitely a varying PR interval. It's not a constant PR interval. Because it's a varying PR interval, not a constant PR interval, and you have a P wave that is non-conducted. You're having a non-conducted P wave and a missed beat because of that. This is another very, very important, interesting example of a Mobitz 1. Okay, this is also an example of a Mobitz 1, not Mobitz 2 for that matter. Sorry for that. And look at this one. Are you able to see any other finding in this EKG apart from Mobitz 1? Any one of you are able to answer? Any other finding you are picking up in this EKG apart from Mobitz 1 which I have shown? Look at what's happening in lead 2-3 AVF. Lead 2-3 AVF, I'm not very sure, but in my eyes I can see a bit of ST elevation for sure. I mean, it's not fitting into the criteria, leave that, but for me there is some ST elevation that's happening in 2-3 AVF. A little bit is there, definitely, there's no doubt about that. Okay, so that is suggestive of probable inferior MI. And I am able to see the reciprocal ST segment depressions also. I am able to see reciprocal ST segment depressions in 1 and AVL, and AVL ST depression is more than ST depression in lead 1. So that also suggests it's an RCA culprit, right coronary artery culprit. And apart from that, are you able to see that characteristic finding? A tall R wave in lead V1 or V2. Along with that, you see that characteristic ST segment depression. Along with that, upright T wave. So what is this going towards? I mean, you should be easily able to answer, isn't it? So what is this going towards? This is, of course, going towards a posterior wall myocardial infarction. So this patient is probably having a infero-posterior myocardial infarction. So because of the inferior MI only, this patient is having a Ventricular Mobitz type 1. In fact, Mobitz 1 and complete heart block are very common. Sinus bradycardia, Mobitz 1, complete heart block are very common with inferior MI because RCA is the one that generally tends to cause inferior MI. But sometimes it can be L6, but RCA is the one that causes inferior MI, and RCA is the one that supplies your SA node as well as AV node as well. That's the reason bradyarrhythmias are very common with inferior MI rather than anterior MI. Especially with RCA occlusion, bradyarrhythmias are very common. So this is another example of a Mobitz 1. Okay, look at this. So this is an example of a Mobitz 2. Okay, but we are going to call it as 2:1 conduction, or we can say 2:1 block. So example of Mobitz 2 with 2:1 block. So what you are seeing here, again, there is a bradyarrhythmia rhythm. So this is definite bradycardia. There is no doubt about that. There are more than 5 large boxes between 2 QRS complexes. So without a doubt, I can make a diagnosis of bradycardia. But apart from that, what you are seeing here is there is a P wave that is not conducting. So there is a P wave that is definitely not getting conducted. So I can have a suspicion of Mobitz here. Remember, if you do not have a conducted P wave, which means P wave is there, but if it's not conducted, then only you're going to suspect Mobitz. Here definitely there is a P wave that is not getting conducted. One P wave is conducted, one P wave is not conducted. And as I told you, one of the quintessential prerequisites for diagnosing Mobitz 2 is a constant PR interval. As you can see, whatever the PR is there in this EKG, it's having a constancy. I'm not talking about a prolonged or a short PR. I'm not talking about the length of the PR. I'm telling whether it is constant or varying. So in Mobitz 1, as I told you, it will be a varying PR interval, but whereas in Mobitz 2, it will be a constant PR interval, and in between there will be one missed beat. So here, for every 2 P waves, only one is conducted and one is not conducted. That is why this is an example of a Mobitz 2 with 2:1 block. Again, please understand, if you have a P wave that is not conducted, then only you're going to make a diagnosis of Mobitz. And coming to this one, so this is an EKG that's an example of a complete heart block for that matters. Remember, whenever you have a complete heart block, number one, you will have a regular rhythm. That's a very, very important. Regular QRS complexes. You won't have irregularity in the rhythm. And number two, you're going to have AV dissociation. AV dissociation means there will be absolutely no relationship between P wave and the QRS complexes. As you can see here, this is a EKG that is showing probable bradycardia, I'm not very sure, 1, 2, 3, 4, 4.5 large boxes. But remember, AV blocks may show bradycardia or may not show bradycardia. That's also a very important point. Many people think like whenever you have AV block means patient will always be bradycardic. It's not that. Some patients with AV block may have a normal rate, or I've seen patients with AV block having higher heart rates also. But nevertheless, so this is a patient who's having complete heart block, maybe having a normal heart rate also. But how can I say it's a complete heart block? Look at the PR intervals. So the PR intervals appears very chaotic. So here you have a one PR interval, here you have a different PR interval, here you have a different PR interval, but there is no missed beat in between. You're not seeing any missed beat. So one of the characteristic finding in MOBITS is there will be a missed beat. There will be a P wave, and after that you will not have a QRS complex. So that's what you're going to see in a MOBITS. Here there will be no missed beat in the sense. I mean, you should not call it as a missed beat because there is absolutely no relationship between the P wave and the QRS complexes, and there will be significant AV dissociation or atrioventricular dissociation. And that is the reason I'm telling that it is not MOBITS 1 or MOBITS 2. It is very likely to be a complete heart block. And how can you further clarify the fact that it's a complete heart block? And you will have a chaotic or a no relationship between P wave and the QRS complex. Here you can see one P wave happening before the QRS complex. Here there is another P wave happening after or before, you can't say, and one P wave is falling over the QRS complex. One P wave is just coming before the QRS complex. So I can clearly say there is absolutely no relationship between P wave and the QRS complex, and that's how I can prove that the patient is having a AV dissociation. And if you have a regular QRS, on top of that, if you have a P wave that is not at all correlating with the P wave QRS complexes at any point, so that is very much suggestive of a complete heart block. So where is the P wave? So there are a lot of P waves here. So this is a P wave. So this is a P wave. So this is the P wave. So this is a P wave. So this is a P wave. So here is the P wave. So there are a lot of P waves in this EKG. So these are all P waves only. So what are you seeing here? Okay. So this is very much suggestive of atrioventricular dissociation, and hence I can make a diagnosis of complete heart block. So Ashwati is asking where is P wave in AVFR. So here is the P wave. So this is the P wave. Here is a P wave. Probably this one I can say it as a P wave, and it sometimes may be superimposed over the QRS complex also. Yeah, see, this is the one that's correlating with this same wave, isn't it? In the same area. So here is the P wave. So here is the P wave, and this is the one that is correlating with the P wave here as well. So there is a P wave in AVF also. Nevertheless, so I don't want to go into the details of that. So this is a EKG that is suggestive of a atrioventricular dissociation, and this patient is having a complete heart block. And coming to this one, so this might look like as if there is a tachyarrhythmia, or as if there is some irregular tachyarrhythmia, but this is a very common EKG asked in INA-CT exams. So this is very much suggestive of something called as sinus arrhythmia. This is very much suggestive of something called as sinus arrhythmia. So what do you mean by sinus arrhythmia? This is the normal respiratory variation in the heart rate. So normally during inspiration, your heart rate will increase. During expiration, your heart rate will decrease. So there is a mnemonic for that, isn't it? I increase. Okay. Inspiration is I, so increase is also I. So normally during inspiration, your heart rate increases. During expiration, because of increased intrathoracic pressure and because of subsequent vagal activation, your heart rate will decrease. So what's happening here is, it looks like as if the rhythm is irregular. If you see at this place, the QRS complex is separated by some distance. At this place, the QRS complex is separated by some different distance. So that's why sometimes you might think that this is an irregular rhythm. Of course, this looks a little irregular, but this is a proper sinus rhythm. This type of rhythms can happen in patients who are athletics, who have very high vagal tone, so that during expiration, the vagus will get activated too much, so that there will be a dramatic fall in the heart rate during expiration. So I can safely say there is a P wave, there is a QRS complexes, and it's happening in 1:1 ratio in each and every beat. So definitely this is a sinus rhythm. There's no doubt about that. And apart from that, I can clearly say at this point that the patient is actually undergoing expiration. That's why the heart rate is a little less. And during this time, the patient is actually going for inspiration, and that is the reason why the heart rate is appearing slightly higher. So this is nothing but a simple sinus arrhythmia. Typically happens in athletic patients, athletic people who are having a very high vagal tone. And here is an example of two most common tachyarrhythmias that you will be getting in exams. So one is going to be your atrial fibrillation and another one is going to be an atrial flutter. So many times you tend to confuse between atrial fibrillation and atrial flutter. So first of all, remember atrial fibrillation is definitely an irregular rhythm. There is no doubt about that. There will be irregular QRS complexes. So you can clearly see the gap between QRSs keep on varying with beat to beat. So that's very classic of AF. Beat to beat variability will be there. And apart from that, you're not able to see any formed P waves. So you might ask, what are these basically? So these are just fibrillating waves. We can call it as small F waves. These are fibrillating waves. And you don't have the undulating baseline. So that's one way to differentiate between atrial flutter and atrial fibrillation. In atrial flutter, you have that undulating baseline or an unstable baseline or a sawtooth appearance. Here, even though it appears as if the baseline is fibrillating, but you don't have that characteristic undulations in the baseline, which will be very prominent in patients with atrial flutter. So this is a patient with irregular rhythm with just a fibrillating baseline, not a fluttering baseline. And apart from that, this patient is not having any formed P wave. So this is a clear-cut example of atrial fibrillation. How many ever times I say this in exams, students tend to forget this very common rhythm. It's so commonly asked in exam, they can ask any kind of EKG with regards to atrial fibrillation because it's such a common rhythm and one of the most common tachyarrhythmias that you encounter in your practice. That's why this is very, very important. And whereas if you see this one, there is a clear-cut difference between this and this. So here there is a definite undulating baseline, as you can see. See, remember the classic flutter everyone knows. I'm not going to show the classic flutter, but these kind of flutter are very, very common. So this is an atrial flutter with 2:1 block. This is actually an atrial flutter with 2:1 block. So if you want to diagnose an atrial flutter, just look at one lead, that is lead 2. At least at a NEET PG level, just look at lead 2. Don't look at any other lead. And you can clearly see how significant the baseline fluctuations are. Here, see, these are just fibrillating baseline. There are no significant fluctuations, but look at this one, how much undulating the baseline is. This is a significant fluttering baseline. So that's why the name is there, fibrillation, fibrillating baseline, fluttering, okay, sawtooth, fluttering baseline. So that is suggestive of an atrial flutter. So, I mean, remember the classic flutter, I know. So if there is something like this, if you're going to have a some EKG like this, okay, you'll be able to diagnose. So I'm not going to show these kind of EKGs. This is easy to diagnose. This is an atrial flutter for sure. But these kind of EKGs are going to be common in practice. So whenever you want to diagnose a flutter, look for the undulating baseline or you look for the classic fluttering baseline or sawtooth pattern. Okay, unstable baseline. So that will make a diagnosis of atrial flutter rather than atrial fibrillation. And look at this one. So this is a classic rhythm again. This is a AV nodal reentrant tachycardia. One of the main differential diagnoses for AV and RT is AV-RT with orthodromic conduction or atrioventricular reentrant tachycardia with orthodromic conduction that typically happens in patients with Wolff-Parkinson-White syndrome. But this is an example of AV and RT or AV nodal reentrant tachycardia. What are the classic features? Number one, the rhythm will be regular. Most of the time it will be narrow complex only. It's a narrow complex regular rhythm. Narrow complex regular rhythm. And you won't see the P waves at its usual location. I won't say P waves are absent here, but you know where should be the P waves. P waves should be before the QRS complexes, right? But here you don't see P waves at its usual location. At this place, you don't see the P waves. So that is AV and RT. So narrow complex, regular tachycardia, and if you don't see P waves at its usual location, think about AV and RT or AV-RT with orthodromic conduction. But more often than not in exam, you're going to make a diagnosis of AV and RT, which is synonymous with something called as SVT. Even though supraventricular tachycardia is a term that is used for any tachycardia apart from the ventricular tachycardia, but usually AV and RT is the one that's synonymously called as PSVT or supraventricular tachycardia. But that should be avoided, at least in modern practice. But how do you diagnose AV and RT? One more time. Regular narrow complex tachycardia with no P waves at its usual location before the QRS. But where will be the P waves? Sometimes P waves, I mean, if you look carefully, you might see that the P waves might be buried within the QRS complex like this. So you can see these are the P waves that are buried within the QRS complexes. But no need to worry about that. nobody is going to ask these kind of things. But anyways, if you see this kind of buried QS P waves that are within the QRS complexes like this, these are called as pseudo S pattern, or sometimes you might be able to see this kind of buried P waves, okay, within the QRS complex in lead 1. These are called as pseudo R wave pattern. So remember, easier to find, it's very easy to find out. So regular narrow complex tachycardia with no P waves at its usual location, but you might see the P waves which can be buried within the QRS complex, like pseudo S in lead 2 or pseudo R in lead V1, which is very much suggestive of a AV NRT rather than a AVRT with orthotropic conduction. This is an EKG of AV nodal reentrant tachycardia. So first line drug is different, but the first line treatment option for AV NRT is going to be vagal maneuvers. Once if vagal maneuvers fail, then only you are going to go for adenosine. Otherwise, you just try vagal maneuvers. Approximately 20 to 30% of AV NRTs can just revert to sinus rhythm just with vagal maneuvers. No need to do anything else. If it doesn't work, then you can go for adenosine. Okay, so this is a irregular rhythm, as everyone knows. So this is a patient with irregular rhythm. So whenever you see an irregular rhythm like this, so first of all, confirm that it's an irregular rhythm. So you can see that there is a definite irregularity in the rhythm. So you can see only 2 large boxes here, but you can see almost 3.5 large boxes here. So definitely this is an irregular rhythm. So most of the times when you see an irregular rhythm in exam, you think about atrial fibrillation. That's natural. But please confirm whether you have a P wave or not. But here you don't have a P wave. In atrial fibrillation you won't have a P wave, but here you have a P wave. But whenever you see an irregular rhythm, okay, in exam, and if you have a P wave, one important differential diagnosis is MAT, that is multifocal atrial tachycardia. So to confirm MAT, you need to see whether you have at least 3 different P wave morphologies or not. So if I take this is morphology number 1 of the P wave, look at this one. So definitely this is a different morphology, and this is morphology number 2, and definitely this is a different morphology, and this is morphology number 3, and definitely this is a different morphology. This is morphology number 4. I can say this is a bifid morphology. This is morphology number 5. So in this EKG, I'm having at least 3 different P wave morphologies, and that is very much in favor of multifocal atrial tachycardia. So how to diagnose a MAT in exam is very simple. See an irregular rhythm. Once you see an irregular rhythm, you always think about AF, but confirm. Look for the P waves. In AF, P waves should not be there. If P waves are there, it's not AF. So if P waves are there, to confirm MAT, you need to have at least 3 different P wave morphologies at least. So look for different morphologies of the P wave. That confirms that it's a multifocal atrial tachycardia for sure. And usually multifocal atrial tachycardias tends to happen in patients with pulmonary disease, and treating the pulmonary disease itself will cure the multifocal atrial tachycardia most of the times. And this is an example of a patient who's definitely having ventricular complexes. So look at how wide these complexes are. Okay, look at how wide these complexes are. So definitely these are ventricular ectopics only. These are ventricular complexes. There is no doubt about that. So look how wide these complexes are. So surely these are ventricular complexes. And what is the heart rate between them? If you look at the heart rate between them, it looks normal. These are continuously coming ventricular complexes, but the heart rate is normal. Right? Just hold on 1 second. ஒரு கிளாஸ்ல இருக்கு, அதை முடிச்சுட்டு போட்டுமா 2 நிமிஷம். Sorry for the interruption. Okay, so you have a continuous ventricular complexes like this, but look at the heart rate between them. So the heart rate between them is looking completely normal, isn't it? So you have 1 large box, you have 2 large box, you have 3 large box, you have 4 large box here. So the heart rate is normal. It is not tachycardic. So if you have a continuous QRS complexes like this with a normal heart rate, always think about one of the possibilities of AAVR, that is accelerated idioventricular rhythm. Normally idioventricular rhythms will have lower heart rate, but if you have a normal heart rate but it's not tachycardic, think about accelerated idioventricular rhythm. So what is the definition of ventricular tachycardia. So to tell it's a ventricular tachycardia, you should have at least 3 consecutive ventricular premature contractions. You should have at least 3 consecutive ventricular premature contractions happening at a rate of at least 100 to 120 per minute. If you have at least 3 consecutive ventricular premature contractions happening at a rate of at least 100 to 120 per minute, then only you can call it as ventricular tachycardia. But AVR, indirectly you can call it as slow VT. You can probably call it as a slow ventricular tachycardia. So that is what we call it as AVR. But this term should be avoided. AVR is a different rhythm. So AVR means you will have more than or equal to 3 consecutive ventricular premature contractions, but they will happen at a normal heart rate. So that's why it's called as accelerated idioventricular rhythm. And look at this. This is not a sinus beat. You can ask whether it's a bundle branch block or not. No. Look at this. There's no P wave. I'm not seeing any P waves at all. So this is a true ventricular rhythm, and there are no sinus beats in this EKG, and this patient is having a accelerated idioventricular rhythm. Maybe this area you're having sinus impulses. As you can see, this is a P wave, this is a QRS, this is a T wave. So this is the place where you're having sinus rhythm. But once you cross this place, you're having only ventricular premature complexes, but they are coming at normal heart rate. Okay, so that's why it's called AVR, accelerated idioventricular rhythm. Usually it is considered to be a reperfusion arrhythmia after a STEMI. So once you have a ST elevation myocardial infarction, you tend to go for reperfusion. That is with either PCA or either with fibrinolysis. Once you have a successful reperfusion, this is one of the classic arrhythmias that you get. It's a very, very benign arrhythmia. You don't need any treatment for this at all. This is accelerated idioventricular rhythm. And coming to this one, this is an EKG of a patient with ventricular tachycardia. First of all, it's not a narrow complex tachycardia as you all know. So this is definite wide complex tachycardia. So whenever you have wide complex tachycardia in exam, you have only 2 differential diagnoses. One is ventricular tachycardia, second is supraventricular tachycardia with aberrancy, SVT with aberrancy. So this aberrancy means aberrancy could be a bundle branch block, or this aberrancy could be a bypass tract like Wolff-Parkinson-White syndrome also. I'm not talking about that, but in exam at a NEET PG level, whenever you see a wide complex tachycardia, always make a diagnosis of ventricular tachycardia. Almost always you're going to make a diagnosis of ventricular tachycardia. I mean, SVT with aberrancy is too much for a NEET PG level, but I mean, I'm not going to teach you here, but anyway, so this is a wide complex tachycardia that is very much suggestive of a ventricular tachycardia. So this is a monomorphic VT, or I told you this is a VT, all right, but this is a monomorphic VT, or is this a polymorphic VT? So to understand that, look at one particular lead. So let us take lead V1 for that matters. Look for the morphology of the complexes. Every single QRS complex in lead 1 is having a same morphology. Okay, there is no difference in the morphology at all. So that is why this is definitely a monomorphic ventricular tachycardia. Similarly, if you take any lead for that matters, if you see lead 2 also, you are seeing same morphology of QRS complexes. So that is the reason why it is basically a monomorphic ventricular tachycardia and it's not a polymorphic ventricular tachycardia. And there are multiple hallmarks that will help you to diagnose whether it's a VT or not. We're not going to talk about that, but these kind of EKGs are very common in exam. That's why I showed you this. So this is an example of a characteristic monomorphic ventricular tachycardia. So Dr. Ajay is asking how will be polymorphic. This is how it's going to look like. So this is an example of a polymorphic ventricular tachycardia. As the name suggests, it's polymorphic. You're going to have different morphologies of ventricular complexes. As you can see here, look at this area. So you see this patient is having a QRS morphology of something like this in one area, and you look at the morphology of this one, it's looking like this, and look at this morphology, it's different, and look at this morphology, it's different. So you're having multiple different QRS morphologies on top of ventricular tachycardia. So that is why this is called as a polymorphic ventricular tachycardia. Remember, whenever polymorphic ventricular tachycardia happens in the setting of a long QT, it is called as torsades. It will be called as torsades or torsade pointer. So that is a polymorphic VT happening in the setting of a long QT. So that's what we called as torsades or torsade pointer. And I mean, there are some subtle differences between a typical polymorphicity and Torsades, but in exam, it doesn't matter if you identify these polymorphic ventricular complexes, which are different in morphology at different places. But remember, you should look at a single area. Only in one lead you need to look at. So, I mean, in one particular lead, you're able to demonstrate different morphology of the QRS complexes, then probably you can make a diagnosis of Torsades. Perhaps the next EKG is something that you will often tend to confuse with Torsades, and this is an example of a ventricular fibrillation basically. So many times I've seen people confusing this with Torsades because they feel that there are different morphologies of ventricular complexes, but remember, here the ventricle is just fibrillating. As I told you, in atrial flutter, I told you, in flutter there are some big complexes, but in fibrillation the complex will be very small and sometimes it will be indiscernible. You don't know whether the ventricle is contracting or not itself. So here you can clearly say that the ventricle is contracting. There are some discernible ventricular complexes going on. But look at this. Look at this area. Look at this area. The ventricle here is not showing any discernible contraction at all. It is just fibrillating. So perhaps, like this is very important to understand because I've seen many students diagnosing this as polymorphic VT, which is very, very wrong. So do not diagnose this as a polymorphic VT. This is a characteristic example of a ventricular fibrillation and not a polymorphic VT. And we know for stable polymorphic VT, you're going to give magnesium sulfate. For ventricular fibrillation, you need to immediately go for defibrillation. So these are examples of pulseless electrical activity. So more often than not, we tend to get a PA like this only. Remember, PA could be anything. If you have any rhythm except VT-VF without a pulse, that is pulseless electrical activity. Remember, VT-VF without a pulse is different. They are shockable rhythms. But any other rhythm apart from VT and VF, and if you don't have a pulse, that is pulseless electrical activity. And look at this one. If you look at this EKG, there is some rhythm going on. So there is some rhythm going on. It's a ventricular rhythm only. But this patient is unlikely to have a pulse. In that case, you're going to call it as a pulseless electrical activity. So these are called as idioventricular rhythms. This is not an accelerated idioventricular rhythm. So this is a very slow rhythm going on. This is an idioventricular rhythm basically. So just you are seeing some broad QRS complexes that are, I mean, typically in emergency room, these kind of idioventricular rhythms which are very slow and with a very broad QRS and all, we tend to call it as going away rhythms because just before the patient's death, these kind of rhythms are very, very common. So unless and until you do something dramatic or if you reverse what is the underlying cause, this patient is not going to survive. But these are, if you don't do anything, this patient will generally pass away. So these are called as going away rhythms. This is just an idioventricular rhythm, and just before death this happens most of the time, and mostly this patient will not have a pulse and this will be associated with the pulseless electrical activity. And finally, this is also another cardiac arrest rhythm. So sometimes you might have some few idioventricular rhythms like this which are indiscernible. On top of that, after that you will get a flat line like this, which is what we refer to as something called as asystole. And this is also another rhythm that is associated with cardiac arrest. These are typical cardiac arrest rhythms. And coming to some special waveforms. So this is an example of a WPW syndrome, or otherwise called as a Wolff-Parkinson-White syndrome. So what will be the characteristic finding of a Wolff-Parkinson-White syndrome? There will be a short PR interval, number one. So look at the lead 2 here. You have the P wave, and immediately after the P wave, your QRS complex takes up. So this is an example of a short PR interval. And it's not only about the short PR interval. The earlier part of the QRS, the initial part of the QRS is very slow and slurred. The earlier part of the QRS, initial part of the QRS is very slow and slurred. So these are called as delta waves. So if you see a combination of short PR interval along with, if you see this kind of initial slurring of the QRS complex, which is called as delta wave, it is very much suggestive of a Wolff-Parkinson-White syndrome. Remember, in exam, you are going to make a diagnosis of Wolff-Parkinson-White syndrome whenever there is, and the patient in question is a child, like a pediatric age group coming with palpitation, syncope. Always keep in mind that it could be a Wolff-Parkinson-White syndrome and look for the changes in the EKG accordingly. And this is perhaps one of the very important EKGs again. So this is a patient who's having a pre-excited atrial fibrillation. Pre-excited atrial fibrillation means this is a patient with WPW syndrome. On top of that, he's having atrial fibrillation. This is a very dangerous scenario. Normally in atrial fibrillation, the AV node is there to protect you. Okay, AV node will definitely protect you in patients with atrial fibrillation and will prevent the complexes from, prevent the impulses from getting transmitted too much into the ventricles. But in a patient with Wolff-Parkinson-White syndrome, the bypass tract makes the situation very dangerous, because it's going to conduct the impulses from AF rapidly into the ventricles. And that's why one of the clues for diagnosing a pre-excited atrial fibrillation is, if you have a patient with atrial fibrillation, means patient will not have P waves and patient will have irregular rhythm. Okay, so if you have a patient with characteristic atrial fibrillation, plus if you have a rhythm that is going on at more than 200 to 300, okay, more than 200 to 300 beats per minute, this is very much in favor of pre-excited AF. Especially, again, look for the gold standard clue in exam, a child coming with this kind of irregular rhythm. Okay, always think about pre-excited atrial fibrillation, because in a routine atrial fibrillation you can give AV nodal blockade, but in a patient with pre-excited atrial fibrillation, AF with WPW, AV nodal blockers are absolutely contraindicated, because AV node is protective to prevent AF from getting the AF impulses from getting transferred into the ventricles. But if you have a WPW now, and if you are blocking the AV node, means all the AF impulses now will get facilitated towards the bypass tract, and you are literally converting atrial fibrillation into ventricular fibrillation. And AV nodal blockers are absolutely contraindicated in patients with pre-excited atrial fibrillation. And routine atrial fibrillation, in fact, the first treatment itself is AV nodal blockers, but in a patient with pre-excited AF, you can't touch your AV nodal blockers, and it's going to result in rapid death. So that's why this EKG is extremely important for exams. As usual, how you're going to make a diagnosis of pre-excited AF? So it will be a predominant wide complex tachycardia. It will be predominantly a wide complex tachycardia, and you won't have a P wave, and the patient will have irregular rhythm. So on top of this, if you see a rate happening at more than 200 or 300, which is impossible to happen in a routine atrial fibrillation, because in routine atrial fibrillation you have AV node to protect from having this much of ventricular rate. Normally in routine atrial fibrillation without bypass tract, if the impulse are getting conducted through the AV node, the rate will not exceed 160, 170. But if you are getting, you can see at this areas and all, the rate is exceeding 300. So definitely this patient is having a bypass tract that is facilitating the transmission of that high amount of impulses into the ventricles, and that's why this is a dangerous situation. That's a pre-excited. So generally the rule is very simple. Child coming with irregular wide complex tachycardia, it's pre-excited. Keep that notion in mind. In exam, a child coming with irregular wide complex tachycardia, it's almost always a pre-excited atrial fibrillation. Always keep that in mind. Okay, coming to the next one. So this is a patient who is suffering from hypothermia, and there are multiple differential diagnoses for J waves, but this is a patient who is having hypothermia. What are the features of hypothermia? Patient will have bradycardia, number one, as the case in this EKG, and second, patient will have prolonged QT, long QT interval will be there, as is the case in this EKG as well. And apart from that, patients will have this kind of Osborn waves. So these are the J wave complexes. These are the Osborn waves that you are seeing. So these are the J wave complexes. So bradycardia, prolonged QT, along with it, if you have J wave complexes, so this will be called as this will be suggestive of hypothermia. And yes, Dr. Gamanaif is saying shaky limb bleeds. These are shivering artifacts. Not only in the limb bleeds, you are also able to see that in the chest leads also. So because patient is shivering here, and these are called as shivering artifacts because of hypothermia. And 45. Okay, this is an example of a Brugada syndrome, another EKG that's very important for your exams. So there are some J wave syndromes. What are the J wave syndromes? Where you can get the J waves? Number one, I told you in hypothermia you can get J waves. Hypothermia. Second, in patients with hypercalcemia, you can get J waves. Number three, in Brugada syndrome, you can get J waves. Number four, you can get J waves in arrhythmogenic right ventricular cardiomyopathy, and you can get J waves in benign early repolarization syndrome. I think we have talked about early repolarization syndrome and we have talked about hypothermia. So this is an example of a Brugada syndrome causing J waves. As you can see here, so these are the J waves that are seen in Brugada syndrome. And Brugada, you know the classic pattern. So it's going to be a atypical RBB, atypical right bundle branch block. In a true right bundle branch block, the R wave will be very tall generally, but here the R wave is not tall. Instead, the S wave is deeper here. That's why it's an atypical RBB, or we can call it as a pseudo right bundle branch block. But nevertheless, you get a pattern that is similar to right band branch block. Along with it, you will get ST segment elevation like this, and you will have a coved segment. In type 1 Brugada, usually you will get a coved ST segment like this. This kind of coving will be there. Okay, this kind of coving will be there, like it's a descending, smooth descending coving type of ST segment. So pseudo atypical right bundle branch block, where you'll have a more deeper S wave rather than a taller R wave, along with ST segment elevation and a coving of ST segment is characteristic of Brugada syndrome, and these changes will be very typically seen in patients with, very typically will be seen in leads V1 and V2, maybe plus or minus V3, but characteristically seen in leads V1 and V2. And of course, like these patients can have risk of sudden death during sleep, and you need to implant a ICD as a main treatment in patients who are symptomatic or having a family history of sudden death. And coming to this one, so this is a patient who's having a arrhythmogenic right ventricular cardiomyopathy. This is an ARVC EKG. As you can see here, ARVC is also a J-wave syndrome. I told you, So now we are going to the third J-wave syndrome. So that is, we have talked about Brugada now we are going to ARVC. In ARVC, what you see is, in V1 typically, you're going to see this kind of J-waves, small J-waves, as you can see here. Generally, they tend to have this kind of multiple wavelet-like appearance. That is the major difference. That's how we make a diagnosis of ARVC. First of all, you need to understand these are very small potentials. These are very small potentials, and they tend to have this kind of multiple wavelet-like appearance. Multiple wavelets will be there. It will not a single J wave. There will be multiple wavelets like appearance. So that is suggestive of ARVC, and this special J waves that is seen in patients with arrhythmogenic right ventricular cardiomyopathy is what we call as epsilon waves. And once again, these patients are at risk of sudden death, especially during exertion. Brugada, patients will die at rest during sleep itself. In ARVC, patients can die during exertion. And that is why one of the main treatment options for these patients is also implantable cardioverter defibrillator, that is ICD. And coming to this one, I think we are moving into electrolyte changes. This is a patient who's having hypokalemia. And what are the findings in hypokalemia? Number one, you will see pathological U waves. That's very obvious here. You can see these are the U waves. Okay, these are the U waves. These are the QRS complexes. This is ST segment. This is T wave. Okay, ST segment and T wave. I think generally T will become flat here. So this is ST segment and T wave. Okay, what is this one? So this is the U wave. So these are pathological U waves. Okay, when you see a prominent pathological U waves like this is suggestive of a hypokalemia more often than not in exam. And you will see diffuse ST depressions. In multiple leads, you are seeing ST depressions. You are seeing diffuse ST depressions in multiple leads. So this combination of pathological U waves with diffuse ST depressions is very much suggestive of hypokalemia. And Karthik is talking about prolonged QT. Yes, that's correct. At an undergrad level, you can call it as a prolonged QT. Not a problem at all. But to be honest, according to most researchers, it's not the prolonged QT in hypokalemia. It's the prolonged QU that happens. Okay, the QU interval is the one that will be prolonged in hypokalemia. Actually, it's not the QT interval. Even though these patients are slightly at risk of developing Torsades and polymorphic VT, but generally understand it's not the prolonged QT. Telling prolonged QT is not wrong, but if you want to be very accurate, it's not prolonged QT that happens in hypokalemia. It is prolonged QU that happens in hypokalemia. Okay, this is the 48th EKG, which is suggestive of hyperkalemia. These are very typical EKGs that you get in exams in patient hyperkalemia. So usually hyperkalemia will be due to either drug interactions, where the patient might be taking two drugs that cause hyperkalemia, like ACE inhibitors and spironolactone, or ACE inhibitors and beta blockers, and ACE inhibitors NSAID, spironolactone NSAID. So combination of drugs that cause hyperkalemia is the usual cause of hyperkalemia, or it could be kidney disease patient like AK or CKD. But nevertheless, so what are the findings of hyperkalemia? So you'll see this kind of tall, tented, symmetric T waves. Please understand, tall, symmetric, tented T waves can be seen in patients with hyperacute MI also, as I told you already. So this T wave is once again very, very symmetric. Okay, this kind of symmetric, tall, tented T waves is seen in hyperkalemia, and it can be seen in hyperacute MI also. Apart from that, there are some other findings that will tell you it's hyperkalemia. One is white QRS. Patients will start getting white QRS, and patients may have absent P waves. So look at the P waves. Where are the P waves here? There are no P waves. Absent P waves. White QRS complexes. Tall, tented, symmetric T waves. So these are all suggestive of hyperkalemia. So what is the definition of tall T waves? Tall T waves means in the limb leads, if you have T wave height more than 5 millimeter, and in the precordial leads or the chest leads, if your T wave height is more than 10 millimeter, then we can call it as tall T waves. So this is the definition of tall T wave. So apart from that, sometimes patient can go for sine wave pattern, and finally it will result in diastolic cardiac arrest also. And apart from that, you can see variety of bundle branch blocks, AV blocks and something, but that's not important. So in the exams, you will get a characteristic EKG that shows tall T waves, white QRS, absent P wave, plus or minus in some leads you might be able to see that sine wave pattern. If you don't treat, it can go for ventricular tachyarrhythmia, or they can go for diastolic cardiac arrest in the form of flat line. And this is an EKG that is very much in favor of hypocalcemia. One of the characteristic findings that you see in hypocalcemia is prolonged QT interval. You will see prolonged QT interval, and more often than not, in hypocalcemia, it's the ST segment that will get prolonged. The T wave will be normal only. You might get T wave changes, but generally the T wave length will be okay, but it's the ST segment that gets prolonged in hypocalcemia, and that is going to result in prolonged QT interval. And there are multiple differential diagnoses of prolonged QT. You have to go for a reading to understand that, but nevertheless, it's a very important finding in patients with hypocalcemia. And generally, if you want to find out prolonged QT in exams, especially in a patient who's having a normal heart rate, look at if the patient has a normal heart rate, and in that setting, if you want to find out a prolonged QT, just take the RR interval, and look at the QT interval. Look at the QT interval. So if the QT interval, if it's more than half of the RR interval, it is suggestive of long QT. This is a simple rule, but to have, for this you should have a normal heart rate. If you have a bradycardia or a tachycardia, it might not apply, but if a normal heart rate, in that setting, if your QT interval is more than half of the RR interval, then probably, vaguely you can say it is a prolonged QT. But remember, it's not the absolute QT that you're looking for, it's the QTC that you have to look for. So for finding out the corrected QTC, you have something called Besset's formula, which states that QTC will be equivalent to QT interval by square root of RR interval. This is Besset's formula. This is also a very important question in exam to find out the corrected QT interval, because you have to correct the QT according to the heart rate. And why ST is prolonged is what is one question that I'm getting. Remember, in an action potential curve, you have phase 0, phase 1, phase 2, phase 3, and you have QRS complex ST segment T wave. So generally, the phase 2 is the one that correlates with the ST segment, right? This phase 2 means it's due to calcium. That is why the ST segment is also strongly influenced by calcium. In hypercalcemia, the phase 2 will happen very fast. That's why there will be a short ST segment. And in patients with hypocalcemia, the phase 2 will be prolonged a little bit. That's why the ST segment also will be prolonged here. That's the reason hypocalcemia will produce a prolonged ST for that prolonged QT interval as well. So this is a 50th ECG. So this patient is a patient who's having hypercalcemia. As I've told you, one of the characteristic feature of hypercalcemia is short QT interval, and you might see J waves, and you might see ST segment elevation as well, and sometimes you might see some T wave changes, and a lot of things you can see in hypercalcemia. But remember, hypercalcemia is also another important condition that produces J waves. As you can see here, I told you the final thing that produces J waves is hypercalcemia. And if you look at this one, these are the J waves, okay, produced by hypercalcemia. You can see the prominent J waves, right? Prominent J waves that you can see, the junctional waves that is seen in hypercalcemia. And here is an EKG that looks like as if there is some ST segment elevation also, especially in V1. If you see, it looks like there is some ST segment elevation, and yes, that's correct. You can see, right? So it looks like as if there is some ST segment elevation also. That's what is happening in this EKG. So you're seeing again the QT is very, very, very short here. QT is very short here, and I don't think you are able to see the ST segment at all in the first place. The J point is elevated so that I can say ST segment is elevated, but I don't know where the ST segment is at all in the first place. Can you see ST segment anywhere, right? See, look at this EKG. I can clearly make out there's such a long ST segment. But in this EKG, all I'm able to make is only the T wave. I don't even know where the ST segment is. So this kind of undetectable ST segment indicates a very short QT, especially due to hypercalcemia. So short QT, J waves, ST elevation, all these are very much suggestive of hypercalcemia. And this is another classic EKG, which is suggestive of something called as electrical alternance or QRS alternance. So what do you mean by electrical alternance or QRS alternance? You're going to see varying QRS amplitude like this, or probably varying QRS axis like this. Okay, if you see a varying QRS magnitude or a varying QRS axis, okay, this is what we call as electrical alternance. In exam, you should always make only one diagnosis with this EKG, that is tamponade. And Dr. Ipsita is asking, what are the other causes? I told you there are plenty of causes. Whenever you talk about short QT interval, short QT typically tends to happen in hypercalcemia. It can happen in digitalis toxicity. I mean, not digital toxicity, just with digitalis use itself, you can get a short QT. So just digoxin, not toxicity, just digoxin use itself can cause short QT. And apart from that, there are some other causes also which can produce short QT, like short QT syndrome, we can say. Some textbooks give even hyperkalemia tends to cause short QT. But anyway, so in exam, whenever you talk about short QT, it's almost always about hypercalcemia only. So this is a patient who's having a tamponade. So if you get this kind of EKG, look for Beck's triad. Always look for Beck's triad. And if they ask you next investigation, it is TT, transthoracic echocardiogram. That will be the next investigation. If you confirm it's a hemodynamically significant tamponade, then you can go for urgent pericardiocentesis with a few exceptions. We're not going to talk about that right now. And finally, last but not the least, this will be the final EKG of the day. So this is suggestive of low voltage complexes. There are multiple differential diagnoses of low voltage complexes. So what is the definition of low voltage complexes? In the limb leads, if you see the QRS amplitude to be less than 5 mm, and in the chest leads, precordial leads, if your QRS amplitude less than 10 mm, that should be happening in all the limb leads and all the chest leads. I mean, either limb or chest, but it should be happening in all of the leads. When you talk about limb or chest, whatever it is. So in all the limb leads, if the QRS is less than 5 mm, or in all the chest leads, if the QRS amplitude is less than 10 mm, this is very much suggestive of low voltage complexes. And there are plenty of differential diagnoses for low voltage complexes, including severe obesity, severe COPD, where the lung is hiding the heart behind. It could be happening in patients with large effusions, tamponade, and more importantly, restrictive cardiomyopathy. In exam, whenever you see these kind of very low voltage complexes, always think about restrictive cardiomyopathy, in particular RCM due to amyloidosis. RCM due to amyloidosis. Very, very important point. Okay, whenever you see extremely low voltage complexes like this, always you have to look at the clinical background, all right, but generally they will give you a patient with restrictive cardiomyopathy, especially due to amyloidosis, because amyloid is something that's going to infiltrate the myocardium, and they can prevent the ventricle from depolarizing properly, and so that the strength of ventricular depolarization will be very poor, and that's why you have to suspect amyloidosis in this situation. Yeah, hypothyroidism also can show low voltage complexes, but in general it will be RCM in exam. But again, look at the clinical history. Remember, ECG is something which you have to always correlate clinically. So there is no single finding you can say that is going to be 100% specific for a particular disease. You need to always think about the clinical picture and then make the diagnosis accordingly. Karthik is asking about poor RV progressions there or not. I told you your RS transition should happen somewhere around. RS transition should happen around V3 or V4. Okay, if it happens, that is normal. So here in this example, I think the patient is having a big R wave in V4, so which means the RS transition is happening normally. So I won't really be commenting that this patient is having a poor R wave progression. So hopefully this is a normal R wave progression, but nevertheless, no need to bother much about this ECG. This is a ECG with a low voltage complex. And I think that's all. I have completed all the 52 ECGs which I want to discuss. Hopefully the session was useful, and wish you all the very best for your NEET PG exams which is upcoming. And I think we'll be going on for another rapid revision session also like what we have done last year. Probably we'll be planning somewhere in the first week or second week of May probably. Hopefully you're going to come and attend those lectures as well, which are going to be extremely high yielding. And let me meet you in the next YouTube session. Till that, stay tuned and all the very best once again. Bye bye.